the second edition of the SICAT WOC India webinar, which is on pediatric hip controversies and consensus. And we have some stellar faculty from international and national. So let us see about the faculties. Our senior member is Dr. Ashok Johari, who is a pediatric orthopedic and spine surgeon from Max Nanavati Hospital, Mumbai. He has been the past president of SICAT, IFPOS, WOT, IoT, and APPOS, and he has published 7 books and numerous research papers. And second is our Dr. Alaric Aroojis, who is the current president of POSI and also the chair of SICAT Paediatric Committee, and he is from Neelavati Hospital, PD Injuda Hospital, and also works at Vadia Hospital for Children, Mumbai, India. He is a member of the International Pediatric Think Tank, published over 85 articles, 15 book chapters, and 50 scientific papers, and over faculty over 275 CME. And third is our Dr. Hitesh Shah, who is a professor and head of Department of Pediatric Orthopedics, KMC Manipal. He has around 121 publications, more than 350 lectures, and published around 12 book chapters and in around 3 books. And last is our international speaker, Dr. Mihir Thacker, who is a pediatric orthopedic surgeon, orthopedic oncologist, and limb reconstruction surgeon from Nemours Children's Hospital, Delaware, USA. And he's also director of the Orthopedic Research Scholars Program. He's also the past chair of SICAT Pediatric Committee, and moderators Dr. Vishnu Senthil, me, and I'm an assistant professor at Government Rajput Hospital, Chennai, and my co-moderator Dr. Aravinth, who is a senior assistant professor and pediatric orthopedic surgeon at Chennai at Government Stanley Medical College. And we have some craze presenters, Dr. Karthick, who is associate professor at PGI Chandigarh, Dr. Sukalyan Dey, and Dr. Moka Siddhartha. Dr. Sukalyan Dey is a pediatric orthopedic surgeon from Guwahati. Moka Siddhartha was a MCH pediatric orthopedic fellow at KMC Manipal. And we have our core executive members, Dr. Arindam Banerjee, who is the president of WOC International and India, who is going to give upon the introductory talk, and Dr. Saseendar Shanmugasundaram, who is the vice president of the WOC India, and Dr. Chinmay, Nath, the secretary. So these are the faculties today, and I over to the first talk to Dr. Arindam Banerjee to give a brief introduction about SICAT WOC India and its activities. Dr. Arindam, sir.
Yes, thank you, Vishnu. And I need to share my slides now. Just give me a second. Okay, can you see the slides?
It's visible. You can make it full screen.
Yeah, it's not happening full screen. Anyway, I think I'll just...
I think it is full screen already.
Yeah, okay. So let's just talk a little bit about World Orthopaedic Concern International and World Orthopaedic Concern Indian chapter. Since this is a WOC program, we want to bring you up to scratch about the organization. So as you know, WOC International is the humanitarian arm of SICAT, and it is dedicated to bridging the gap between the haves and the have-nots in orthopedic surgery. Historically, volunteers from developed countries have donated their time and skills to developing nations, and the work of WOC was to match the donors with the recipients, and in the past used to do this by face-to-face when virtual presentations were not possible. This was done by arranging their fares and airfares and local hospitality. At this point, we are doing most of our work virtually post-COVID, but we expect to go back to both virtual and face-to-face programs very soon. Currently, we are doing a lot of work. For instance, we have been asked to arrange an orthopedic course in Somalia, which is currently pending. Now, we have also signed a MOU with a Washington, DC-based think tank, which does a lot of work in Africa. They're a group called Corvus. Very recently, we've signed a MOU with a big group called Surge Hub, which is backed by both the UN and the WHO and is based in Geneva. And this group has in fact asked us to review programs, videos, etc. on their work, on the courses. And we are actually in the process of reviewing their work. From 2 courses are being held, one in Western Australia, one in Oxford, and we are in the process of reviewing this. Similarly, they have also asked us to create content, and I would request everyone participating that if you have surgical videos, if you have very special operations or even standard operations which have been done very well, please send it to us and we will forward it to Surge Hub. And Surge Hub has a very complicated process of choosing, but once they choose it, then you will get a lot of traction from this organization and they will send it to various people all over the world and they can see your work. We have had we have a lot of joint programs with SICOT, with VIOT, and in fact, we have also been, I have interacted personally with Harvard Medical School, and very recently Harvard Medical School has again sent us, this is about 2-3 days ago, a list of webinars which are being held worldwide, and they have asked for speakers. So I will be sending messages through various WhatsApp groups, and if you want to speak on these, then you're very welcome to come and give a lecture for Harvard, virtually, of course. The other thing we are thinking of doing, and we are working on a group with USA, is that we are in the process of setting up a virtual museum, which is currently based in by a group in Kentucky, but we are hoping to open a face-to-face museum in Kolkata. This will be a museum on orthopedic implants, and the donations will come from Kentucky. So we've just bought a property in Kolkata. It will start in a small way, but it will be a good opportunity for people who are interested in implants to research and send their postgraduate trainings to learn things. In addition, there are various implants which need to be cataloged, and we will ask everyone to give their knowledge and take this project forward. So this is going to be after the book on implants. This is going to be our next project. Currently, we have an active website which is being updated and a newsletter which I was the last editor, and I've just handed over charge to Saseendar, who has actually upgraded the newsletter in a big way by bringing a lot of new audio-visual tools. So this is going to be available to all people who are interested, including WOC members and members of WOC allied organizations. This is the executive committee, and this is not the entire committee. There are 1 or 2 people who are just waiting to join, and I'm sure some of you will be interested. Dr. Ashok Johari was my mentor in this organization. He's the one who encouraged me to play a leading role, and I hope many of you who are today participating in this seminar will also be part of this group, as well as the group based in India. The role of WOC International has been increasing. My predecessor, Ala, has added several groups from the Middle East, and they're in the process, and also from Africa, they're in the process of joining us. The most 2 active groups of WOC chapters are the UK and Netherlands. Now, technically, they are not under the WOC International, but we have actually got very good terms with them, and these sovereign bodies have representatives on our board. The other new chapters which are being added, of course, will be under the WOC framework. And while they will be independent to run their own programs, they will be able to cooperate and participate with WOC International and with other national organizations of the WOC on a regular basis. Now, the old WOC India, and there's a little confusion on this, sort of failed to register itself. It was run by a different board. But we have registered a new organization, and we have got everything regularized. In fact, we had to unfortunately pay a huge amount of money to the income tax, which for some donations we received. And it has been registered under the name of Empathetic Orthopaedic Concern Kolkata. It has formed a new board. Till date, many of the board members, I'll show you the list. They are on this webinar, and we have held 5 webinars in the past. Most of them have been covered by OrthoTV, and this is the 6th one. So we are also planning a live program in a medical college very soon, and a national meeting is being prepared in Kolkata on the 18th of May. There will be a program on the 17th evening for outstation faculty. We'll have a faculty dinner. I will send you all the brochure and details as we progress. This program will be done by the WOC India group, but in collaboration with WOC India. International. This is the WOC International Executive Council, and many of them are attending this particular meeting. Now, apart from this, as I said, we've had a lot of collaboration with Harvard Global Orthopaedics, and I had the opportunity to go to Boston and talk to them about some projects which we've done, and of course another talk which they asked us to give there. In addition, we have interacted in Egypt with Viot. You can see some of the programs. And of course, we have our annual meeting in SICOT in 2022. We had it in Kuala Lumpur, in Cairo in 2023, in Serbia, Belgrade, Serbia in 2024. And again, we will be doing our program in 2025 in Madrid. Apart from that, a lot of national programs are being held. Dr. Professor Taneja has regularly been doing programs in Indore, including courses for technicians. In Kolkata, Dr. Ujjal Debnath has been running the 16th, this time the 16th Operation Straight Spine, where they deal with scoliosis and where the faculty are taken from various groups, including the past president of WOC International, Dr. Ala Ahmed. Recent activities of WOC India include several webinars. As I mentioned, Dr. Chinmay Nath who's a back surgeon. He did a low back pain webinar, which had 400 live hits on OrthoTV. We've had Dr. Saseendar, who's done programs, including a program in collaboration with Clarnet, which is a GP-based group. Dr. Vishnu has done one on musculoskeletal infections. Then there was another one by Vishnu is doing this pediatric hip problem group. And again, we have something planned, I think, in February with Dr. Chinmay Nath in a medical college. So we feel that this WOC organization has a lot of future. It has a lot of, there are a lot of bright people on this. And as I said, we are going to try to move from our virtual model to a face-to-face model. So there will be both aspects of it. So those of you, once we can gather enough funds, you will be all able to participate in face-to-face programs. And once we can do that, I think our outreach will increase in a big way. And I think we will benefit. We have also opened up life membership for WOC International. This is $350, which has to be paid to our bank account in America. And we've also opened up WOC full membership, which is going to be valid for about 5 years, and it is at the cost of rupees 5,000. So we will keep you posted about further programs. And with this, I will stop here, and I will request the first speaker from this webinar to start with the academic discussion. Thank you.
Thank you, sir. Thank you for the excellent introduction. I think all the participants will have a clear idea about WC and their work. So without any further delay, we will be going into the academic session of today's webinar. So the topic for today is Pediatric Hip Controversies and Consensus in 2025. And the first speaker will be none other than Professor Hitesh Shah, my guide. So he will be giving talk on controversies and consensus in management of Perthes disease. I think he's the right person at present to give a clear idea about both the controversies and consensus in the management of Perthes disease. Over to you, sir. Thank you.
Yeah, Arvind, screen is visible?
Yeah, yes, sir. It is visible.
Yeah. Good evening, one and all. Thank you very much for WOC for giving opportunity and making the webinar on a pediatric hip. I'm going to talk on consensus and controversies in Perthes disease. Though the Perthes disease has invented 115 years back, still the consensus and controversy runs together throughout the world. The practice in the several parts of the world would be different. Few are doing treatment conservatively, while some of treating the people operatively. So that before starting, I must say that the more you know, more you realize you don't know, which is quoted by the Aristotle, actually is true for the Perthes disease. However, I like to justify in 12 minutes what is the consensus and what are the controversies. All of us knows that self-limiting idiopathic avascular necrosis of the capital femoral epiphysis, so that at the onset, the AVN is visible on the capital femoral epiphysis, and when it healed, the femoral head, the sclerosis disappear, and it may be round, regular, or irregular. So what are the consensus for the goal of treatment is to prevent the secondary deformation and ultimately lead to the secondary degenerative arthritis. There is no ambiguity in the long-term management of Perthes disease to prevent the secondary osteoarthritis when child become adult. Hence, we need to know about to prevent the coxa magna, coxa irregularis, and coxa brevis is the main goal of the treatment. We need to know about the natural history, and again, the natural history don't have any controversy on that. It passes through the stage of the avascular necrosis to the stage of fragmentation, healing, and the reconstitution completely. So what is the consensus in the stage of disease? Each Perthes disease is divided into 3 frames: early, late, and healing. So another point is very important, that when is the maximum deformation of the femoral head happens? Because the stage of the advanced fragmentation, the femoral head is weak and the strength of the epiphysis is weaker to withstand the forces across the hip. And there is a critical stage where the extrusion happens. So hence, in terms of the natural history, the stage 2B is the most important, because the most of the deformation happens at stage 2B, at the late stage of the fragmentation. Hence, if we try to do any treatment before the stage of advanced fragmentation, that would be the preventive intervention. If we want to do anything after the stage of the late fragmentation, it may be remedial intervention. And once reconstitution starts, there may be the salvage surgery. There would not be any ambiguity on this. There would be the clear-cut consensus on that. So the timing of the intervention is the key for the success. There is no controversy on that. However, the consensus on early, there is an issue would be operative or non-operatively, femoral or pelvic. We will come to on that. The important aspect is the timing. Timing for the containment surgery would be before the stage of fragmentation. So let us see the variables that will affect the outcome of the Perthes disease, and the consensus for that, the age of onset. Earlier the onset, the prognosis is good. The late the onset, the prognosis is poor. If the child present less than 6, we need to have a good outcome. If the disease is in adolescent, we'll be having the poor outcome. Similarly, the extent of head involvement, way back 55 years back, Cattrall described the 1, 2, 3, 4. The smaller the Cattrall, the good outcome. The larger 3 and 4 would be associated with poor outcome. There would not be any ambiguity in the treatment. Similarly, there is a amount of collapse. The Haring divided in 32 years back, the lateral pillar classification, and A would be always associated with good outcome, while C is always associated with poor outcome. The green has put that the extent of the epiphyseal extrusion would be associated with the poor outcome. So if the epiphyseal extrusion happens, we need to do about reversal of epiphyseal extrusion. The range of motion, good range of motion would be associated with good outcome. Poor range of motion is associated with poor outcome. The stage of disease we have already discussed. However, there is no level 1 study to show superiority or inferiority result among all these variables, because there are the multi-variables would be affecting. So we'll discuss that one by one. So there would not be any, the controversy is if we consider about the single factor, there is always consensus. But then when we consider about the multiple factor, would come controversy. If we see the age of 6, we understand that it is always associated with good outcome. Let us discuss one of the important aspects, that prognosis is good in younger child. So if we see the 6-year-old child, we need to know that that will be associated with good outcome. It's waited for the stage of fragmentation and healed uneventfully and completely good spherical hip at skeletal maturity. We need to see the second hip. Do we behave the same like the first hip? We treated with the same. However, there is an extrusion happens. So second variable came in picture. So we need to do the reversal of extrusion. Ultimately, it healed well and good spherical hip. Compared to the first two case, yes, the child is 2.5, very young, presented with the right side of Perthes, but there is a severe collapse. So if we see the severe collapse, waited, and as the child is grows, we need to say the advanced stage of the fragmentation, and then it's still there is no extruded. After the stage 3B, it's extruded, and the child ultimately healed with the aspherical femoral head, coxa magna, and coxa brevis, though the child's age of onset was very young. So it's not always the age of onset is only the isolated factor. The healing time in young kid is not always short and outcome is not always great. So there is a controversy among the age of onset. What are the another controversy? The extent of involvement. If the head is involved more than 50%, it is associated with poor outcome. But it cannot be predicted in case of the stage of AVN. It is only predicted in late stage of fragmentation. That may be too late. We'll give you the example. The both child presented in the stage of AVN, but both were treated with the same manner. However, one got the good outcome, one got the poor outcome. Why? Because the extent of involvement cannot be detected in early stage of disease. So what should be the treatment? We can do the perfusion scan in early stage of AVN and find out how it is a hypoperfusion. It is having good reproducibility and reliability. So we'll show you some example. This is a child with 80-year-old did the hypoperfusion. It was less treated with the same, got the good outcome. When the hypoperfusion is that less, it will be associated with good outcome. Second case, when there is the case, it's we did the perfusion MRI, when the hypoperfusion almost like 94%, it will be associated with the poor outcome. The third case, it is in between. The hypoperfusion was 78. It treated with the varus derotation osteotomy. It got the good outcome with sphericity deviation score is 0. So what is the lesson? The perfusion MRI is useful in early stage of disease. However, how much is the cutoff value for the poor result is unknown. Further study will guide us in this matter. What are the controversies? The amount of the collapse would be associated with the poor outcome like herring C. But can we prevent the collapse? The answer is we don't know. The extent of epiphyseal extrusion, but how much is extrusion is a cutoff? We don't know. What should be done in the late stage of disease? There is no consensus. There is a lot of controversy on that. Few cases like 6.5 years with completely flat, it should be considered as the herring C and considered as a Catral 4, managed with the video, it got the reasonable outcome 9 years later. Another case, there is a herring C. It's presented in a stage of the American fellows always say the herring C will never associate with good result. Treated with the varus derotation osteotomy, 7 years later, we can say it's a good outcome. So few controversy, the containment is been given by the many people, including the Scandinavian countries and Indian countries, a lot of literature from Europe as well as the United States. However, the same concept has been recently challenged by the Perry, just whether the containment is useful or not. Few controversy whether to do femur tibia, whether the femur or acetabulum, operative or non-operative, whether to do varus, how much to do the varus, what is whether to do additionally varus derotation or extension, whether to do the Salter or triple, whether the trochanteric epiphysiodesis is useful or not. Yes, trochanteric epiphysiodesis would be useful. Like this is the example at the skeletal maturity, the articulotrochanteric distance is almost equal in that. However, it may in 10% of cases, it may not be required. It may be unnecessary. So we need to find out what are those 10% cases. Similarly, this case was treated with the varus derotation osteotomy, trochanteric epiphysiodesis. Ultimately, in follow-up, we see that trochanteric epiphysiodesis was not effective because proximal screw was not holding. Ultimately, it was treated with trochanteric relative neck lengthening and child has got the good outcome ultimately. The same has been proven recently. The limp is less with the prophylactic trochanteric epiphysiodesis. Last controversy, the weight-bearing status. The weight-bearing status has been given by recent MRI in the Vancouver group. They got the dynamic deformation of femoral head. In weight-bearing MRI shows that more deformation in weight bearing and negligible deformation on non-weight bearing. Similarly, this article was also published from our center that's prolonged weight bearing, it increases chances of the favorable outcome, but same is not followed in different part of world. Summary, I like to say that the reason for poor outcome would be not single, that maybe the older age, severe involvement, severe collapse, biological plasticity, extrusion, and continuous weight bearing in a late stage of fragmentation and severe stiffness hip. So I like to quote that the famous painting with the 6 blind people, when elephant is standing, the person is thinking blind fan is there. What is that character of elephant? So they say it's like a spear or a fan or a wall or a tree, depends on which part of the elephant they are holding. Similarly, if we see the Perthes disease, we need to say the age of onset, extent of involvement, stage of disease, and range of motion. However, there are the few more points: BMI, greater trochanteric epiphyseal disease, bisphosphonate, weight bearing, and perfusion MRI do play a role. So in short, I need to say that prevention is better than cure. The various factors affect the Perthes disease outcome, and early detection of the Perthes with different variables are the key for the successful result. There is no level 1 evidence for the superior about the others for prognosis. It is likely to get answer from the IPSG, International Perthes Study Group study. Thank you for your attention.
Thank you, sir. Thank you for that elaborate talk. If there are any questions from the faculties, we can take 1 or 2 questions before we go to the next speaker. Okay. There are no questions, sir. Sir, perfusion MRI. So, till what stage will you recommend to take it as a routine one, sir?
Yeah, we need to do the perfusion MRI when we do see the child with avascular necrosis stage. In late stage of fragmentation, we can see what is the extent of involvement. So there is no point of doing perfusion MRI. We need to do the perfusion MRI because if there is cateral 3 and 4 would be associated with poor outcome. So if you see the hypoperfusion more than 50% in younger child between 6 to 8, it will be very useful.
And you have told me that there is no cutoff clearly to say like till after what percentage you will have poor result. So,
yeah.
But then can we say that if it is more than 50%, definitely there will be some poor result will be there. Like that we can tell the patients like when we do.
So if we do early intervention, we may get the good outcome. However, we don't know the 60% is better. What is the cutoff limit, whether 78% or 88% or 98%? What is the cutoff for the poor and good result? See, if we do the early intervention above the 50% hypoperfusion, it would be good rather than waiting for the non-operative treatment.
When we are having a that hypoperfusion MRI less than 50%, and it is
then it doesn't require the surgical intervention. Definitely, it doesn't require surgical intervention.
So what will be your non-weight bearing time for that children? Because
up to stage 3B.
Up to stage 3. Okay, sir. Yeah. Thank you, sir. Thank you so much. We will go to the next speaker. So the next speaker will be Dr. Alaric Aroojis, sir. So he will be giving a talk on consensus in screening guidelines for development dysplasia of hip in India. So sir is doing a lot of work in this, and he will be giving us a clear idea of what to be done and what not to be done. Thank you, sir. Please go.
Thank you, Aravind. And when Vishnu invited me to put some topics together for this webinar, I think the theme of controversies and consensus was really apt because there are many things in pediatric orthopedics where we do not have enough of consensus. And when it comes to DDH, there are indeed several controversies, not only in the diagnosis in terms of screening, but also there's a lot of controversies regarding the management of DDH as well. But in this talk, what I'm going to highlight is how did we develop consensus in terms of screening? And this is some work that we have done from India led by the Pediatric Orthopaedic Society of India. So I'm happy to present this today and hoping that these guidelines that we have established become popular not only in our country, but in other neighboring countries which have a similar healthcare system as ours. For the general orthopedists who are attending this webinar, I'm sure you're all aware that developmental dysplasia of the hip, or DDH as we call it, is a spectrum. And the spectrum ranges right from a mild dysplasia at one end to a completely dislocated and irreducible hip at the other end. And while we know that the incidence of a dislocated hip is about 1 in 1,000, clinical hip instability is far more common, and that can be seen in almost 1 to 3% of neonates. If we do an ultrasound, we find that dysplasia is even higher, and about 5 to 15% of typically developing neonates will also have evidence of acetabular dysplasia. The good news is that more than 80% of these mild early dysplasias will resolve in the first 4 to 6 weeks of the child's life, and therefore the true incidence of a hip dislocation is what has been given as 1 in 1,000. It's good to look at DDH through the lens of common birth defects. And if you look at the common ones, we know that congenital heart disease is one of the commonest birth defects that children are born with. But DDH is not uncommon. And for many who think that DDH is a condition that is only seen in the West, enough of literature has been published from India to show that the incidence is the same or even higher. It's definitely much more common than even clubfoot, which is a very visible and obvious deformity, and for which treatment is now well established. But DDH is also a common condition. It's just that we are not diagnosing it enough, and therefore we are seeing a lot of cases coming to us presenting late. We know that the diagnosis of DDH in infancy is not easy, unlike a clubfoot or a cleft lip and cleft palate, which is quite easily visible. DDH is a sign which needs to be elicited, and therefore many pediatricians need to be able to be competent in performing the Ortolani and the Barlow tests. And we know that an ultrasound can pick up most of these images, but of course, ultrasound is a diagnostic modality that is not very easily available, especially the expertise in performing a neonatal hip ultrasound is not very easily sought in our country. An X-ray, of course, will be useful to diagnose DDH, but not in the first few months of life. Really, we know that most of the femoral head is cartilaginous, and we have to use surrogate markers to diagnose DDH when we are using X-ray to diagnose it in a child who's less than 4 months of age. Whatever the mode of diagnosis, we are all well aware, and it's been evidenced out in literature, that early diagnosis is equivalent to an early effective treatment. If it's picked up early, it can be treated very simply in a Pavlik harness or by a closed reduction and a hip spica. But very often in countries like ours, we see that the diagnosis is missed, and hence children come to us after the walking age, where not only is it more difficult now to reconstruct the hip, but there's a much higher incidence of complications such as redislocation, avascular necrosis, and it's also an expensive condition to treat, which is not really apt for a developing country like India. We know that around the world, there have been several national and regional hip screening programs, and unfortunately, these are meant for that particular population or healthcare system that they have been developed for, and are not always transferable to developing countries such as India. What all of these screening programs have shown, whether they are in the German-speaking countries or the Scandinavian countries, that wherever they have been implemented, there's been a marked reduction in the incidence of late-presenting DDH, and is therefore the standard of care globally. The American Academy of Pediatrics and the American Academy of Orthopaedic Surgeons have also published guidelines for screening for DDH, but how many of these guidelines are really applicable to a country like ours? So we know that in a country like India, there is a very poor awareness about DDH among pediatricians and allied healthcare professionals. We know that the ultrasound is available all across our country, but its use has been restricted because of the stringent Preconception Prenatal Diagnostic Act. And therefore, the expertise in performing a neonatal hip ultrasound is restricted to a very few urban areas in major cities. Furthermore, we don't have a structured surveillance program. And therefore, there's little benefit in diagnosing DDH early if there's no pathway for referral or further treatment. I don't need to belabor this point for us from India, but we know that as the most populous country in the world with a high number of births, and a healthcare system which is not so good, because less than 1% of our GDP is allocated to healthcare. And we have this dichotomous healthcare system where even in the rural areas, more than 50% of healthcare is delivered by the private sector, and that's even more in the urban areas. So we decided that it's time that we as an organization, when I say we, I mean the Pediatric Orthopaedic Society of India, that we take a stand and decide that it's time we develop screening guidelines for DDH in our country. And the best way we felt to do this was to liaise with the various large academic organizations, such as the Indian Academy of Pediatrics, the Neonatal Forum, the Radiology and the Ultrasonography Associations, and of course our parent body, the IOA. And we did get funding support and technical support from the International Hip Dysplasia Registry and from the BC Children's Hospital, for which we are extremely thankful. So we realized that to create a screening pathway or guidelines, it's not an arbitrary phenomenon. We need to follow the 4 important principles of creating awareness, generating the evidence from literature, developing consensus where evidence was lacking, and then finding ways to implement guidelines that we established. So we went about this in a very scientific manner, going through 3 different phases, each one lasting about 4 months or so. And we were lucky that during the COVID pandemic, we found enough of time away from clinical practice to have these various webinars and online calls so that we could then establish these guidelines. So the first step was, as I said, setting up the multidisciplinary expert committee to create awareness about the magnitude and incidence of DDH by various Zoom calls and infographics. We had a survey of the various members to determine the current screening practices and the potential obstacles to developing a screening pathway. And we also undertook a very detailed review of literature on what are the existing practices for DDH screening. The next step of 4 months was in developing consensus using the evidence from literature, and where the literature was lacking as far as evidence was concerned, we then fell back on the consensus using the Delphi approach. And I don't expect you to read this slide, but the Delphi approach was done in 2 or 3 sittings, where we finally came out with 35 consensus statements surrounding the importance of clinical examination, the role of ultrasound and X-rays, how to do decision-making for screening, and how to look at risk factor screening. And therefore, in the last phase, we actually framed the guidelines with a co-writing team, having members from each of these various organizations, and also developing various knowledge translation tools that would assist us in active dissemination. So for those of you interested, I think this guidelines is something we want to really implement all across our country. If you scan this QR code on your mobile phone, it will take you directly to our website, and the guidelines are available as a free download on that website for you to stick up in your clinic, for you to distribute to your pediatricians and various other healthcare colleagues, to make these guidelines really popular and implemented in our country. We also published this in Indian Pediatrics, which is the official journal of the Indian Academy of Pediatricians, so that the main stakeholders, who are the pediatricians and neonatologists, are well aware of these screening guidelines. So what is unique about these guidelines? These are guidelines which are relevant to the healthcare context. They are made in India for India. They are broad-based enough to remain applicable to the diversity of our healthcare settings. The focus here is on surveillance rather than screening, which emphasizes the concept of periodic examination rather than a single episode. And I think what is crucial is that we have aligned the screening with the national immunization schedule at birth, 6, 10, 14 weeks, at 6, 9, 12, 15, and 18 months, which is very successful in our country and which bring millions of children into the Well Baby clinics for vaccinations. And we felt if we can encourage pediatricians and neonatologists that every time the child comes for vaccination, to spend a couple of minutes in examining the hip and trying to screen for DDH and then referring them on further if they find an abnormal result. We also have given guidelines for very age-specific clinical tests and the use of ultrasound selectively, considering that it is limited in availability and the lack of expertise in interpreting them in India. We've also lowered the age for X-rays because we understand that it is a tool which is easily available all across the country. And we are recommending that even at 14 weeks of age, if you don't have access to an ultrasound, get an X-ray done because the risks of radiation are far less compared to the risks of missing a DDH. So I'll briefly in the next couple of minutes run through what these guidelines are about. The focus on our screening program is on clinical examination. We haven't yet reached the maturity where we can recommend universal ultrasound screening for the reasons I've explained to you earlier. But if you screen children well using these 4 important tests, less than 14 weeks using the Ortolani and the Barlow test, and for children more than 14 weeks using limited hip abduction and a limb and discrepancy diagnosed by the Alice or the Galeazzi sign. If you find any of these tests positive, then the pediatrician is supposed to refer the patient directly to a pediatric orthopedic or an orthopedic surgeon for further evaluation and treatment, and there's no further things to be done by the pediatrician then. But if the clinical examination is negative, the next step is to do risk factor screening. And risk factor screening, we are emphasizing on 4 important risk factors: a breech presentation, a positive family history in a first or second degree relative, a history of improper swaddling, and a history of hip instability. If any of these are positive, then you look at the age of the child. If the child's age is less than 3 months and you have an ultrasound available, then we would schedule an ultrasound at 6 weeks of age. If it is not available, then you can schedule the child for a pelvis X-ray after 3 months of age. If the child is already older than 3 months, if you have an ultrasound, go ahead, do it, but otherwise rely more on an AP pelvis X-ray. And if the child is more than 6 months, then of course you can directly go to an X-ray. If any of these are abnormal, refer the child immediately to an orthopedic surgeon. The last point is about a specific group, which is the positive Barlow. We know that a positive Barlow is quite okay in a child less than 6 weeks of age, and nothing needs to be done for that as far as treatment is concerned. But we must be aware that if they are more than 6 weeks, they need to be referred to an orthopedic surgeon. So in a positive Barlow, again, if you have an ultrasound available, you should refer these children for an ultrasound at 6 weeks, not before, because we know that 90% of positive Barlow tests will recover in the first 6 to 12 weeks. So following these guidelines, we've also developed some knowledge translation tools. We are in the process of developing various short YouTube videos and tutorials for pediatricians and neonatologists to help them understand how to do these 4 important tests: the Ortolani test, the Barlow test, the Alice or the Galeazzi sign, and restricted hip abduction. So 4 simple tests that we need to teach all our healthcare workers using various pictures and videos and other forms of tutorials to help them understand how these tests should be performed in children every time they come for a vaccine visit. So in conclusion, I would say that while developing these guidelines, we have learned a few lessons along the way. We have understood that we need to involve all relevant stakeholders right from the beginning. It's important to understand that for each healthcare system, what are the potential barriers, and to find ways to overcome those barriers by developing knowledge and awareness. We understood that we should follow a feasible, multi-phased, evidence-based approach to guideline development, because rather than just developing guidelines which are never going to be used, if they are scientific and if they are published in peer-reviewed literature, on websites and various other modalities, only that will stand the test of time. And then the next step is, after developing guidelines, how do we implement them? How do we consider the support of local champions, organizational leaderships from various organizations, and also approaching the government to incorporate this as part of their screening program through the RBSK program under the National Health Mission. So I would like to acknowledge the role of all our partners who helped out with this project. Here are the names of the various people who gave time and expertise over a span of almost a year in going through the various literature available on DDH screening and helping us to develop these guidelines, and also funding support that we received from various nonprofits and the University of British Columbia. Thank you very much for your attention.
Thank you, sir. That was a very detailed talk on screening of DDH. As wise people say, what your mind does not know, your eyes will not see. So DDH is one thing that if you don't look for it, you can easily miss it. And I think POSI has taken a very right direction in identifying how to screen this DDH in a very, very basic level, and then inculcating it with the immunization schedule is one of the best things that we can do in an Indian scenario, where people are now well aware of vaccination, so they will definitely bring it to a health center where we can screen it. That was a very nice initiative, sir. Thank you so much for that excellent talk. And any doubt from the speakers, I think we can, from the participants, we can take at the end of the session. So without wasting further time, we will go to the next talk. So now I request Professor Ashok Johari, sir, to give his talk on hip displacement and cerebral palsy, consensus in early detection and management. Please, sir. Thank you.
Thank you, Aravinth, and greetings everyone who's on this webinar. For me, my job is relatively easy, because this is a field where controversies are fewer and consensus is more. I'm talking about hip displacement in cerebral palsy. Again, a very, very important topic. Now, we all know, that cerebral palsy is a lever arm disease, and levers function, there is muscle imbalance, and for that reason, the hip in a cerebral palsy patient is abnormal and is always in a state of flux. It's always in a state of flux and likely to dislocate or subluxate. It's an unstable hip. Now, here's an example. This child, 2 years and 10 months old, 4 months later, a repeat X-ray shows that the hip is virtually out. So there's imbalance between the flexors and adductors versus the extensors and abductors. And because of this imbalance and force couples, the hip can easily become unstable, can subluxate, or can dislocate. So what happens in cerebral palsy is that because of this unequal couple forces which are present, the center of rotation actually shifts from the center of the femoral head to the lesser trochanter. The iliopsoas and the adductors pull the hip in one direction. The abductors and extensors are not able to balance this, and that is why you have a stretch on the ligaments and capsule, and then eventually a subluxation or a dislocation. Here's an example of a patient, a 5-year-old patient who presented to me in 2004. The hip was clearly becoming unstable on the left pane. The Shenton's line is broken and the hip has started migrating up. We mentioned to him that treatment is required. We sort of impressed on him that this is necessary to treat it now because it can get worse. Well, no treatment was sought by the family. We see the further sequence of events. They followed up regularly but didn't offer any treatment. So 8 months later, the hip has subluxated further. December of 2004, nearly about 35% of subluxation is present. 35–40% of the femoral head is out. And then you see the sequence over a number of years. In the 2007 slide, you can see that the femoral head has changed shape. It has got flattened, because of the forces of adduction, adduction and flexion. That part, the inner part of the femoral head has changed shape. 2008, the displacement is more than 60% with the change of the femoral head shape. Also, the acetabulum is worth looking at, because the acetabulum becomes more and more dysplastic with the head being off center. Another patient here who presented to me in 1992. Well, this is typical of patients who have a hip problem, crossed lower limbs, adducted hips, adducted thighs, difficult to abduct. This is a GMFCS5 patient who was bedridden. Presentation in 1992 in the slide on the left side, in the picture on the left side, and then presentation in 2001, that is about 9 years later, with severe pain. You have absolutely the cartilage is gone, and this child became very painful with a lot of night spasm, night cries. Another example of a femoral head deformation. Marked change in the femoral head shape. This child also had scoliosis. Well, this is a GMFCS5 child who's bedridden, and who has severe problems at the hip as well as at the spine. So if one way to open these hips, one sees this picture, where the cartilage is completely eroded, and this is called end-stage hip disease. Because when the cartilage is so much eroded, they are virtually, very likely, they lose the ambulation potential completely. So pain becomes a foremost symptom, at this point in time. Important about cerebral palsy is that hip displacement is insidious. and progressive. This is more a question of detecting this problem, rather than controversies. Of course, there are some controversies everywhere, but the problem is of creating awareness amongst those handling cerebral palsy patients that hip can displace very insidiously, and this displacement can get progressive over time, leading to a situation where the cartilage gets eroded and the hip becomes painful. This is the natural history in cerebral palsy. Once a hip begins to subluxate, it rarely improves without treatment. And with progression, there is an increasingly adverse effect on hygiene, sitting, and gait, as well as pain by early adulthood for many of those affected. Now, these are very, very old papers, but still, this knowledge is not common. We know that hip displacement increases from GMFCS level 1 to level 5. This is a paper by Su based on the Australian population. Well, 90% of hip displacement in GMFCS 5, 69% in GMFCS 4, and then it goes down. As you go down to GMFCS 1, it's 0%. But bedridden patients, no one bothers much about them. The family is not very much bothered, But these are the very children who have hip instability, hip subluxation and dislocation, and very likely to need treatment because of pain eventually. Well, hip subluxation or dislocation can start very early in life, and the peak for subluxation is somewhere around 3 to 4 years of age. The peak for a hip dislocation occurs around 5 to 6 years of age. So screening becomes important from the beginning, when you diagnose cerebral palsy for a patient, if the patient especially is a GMFCS 4 or a GMFCS 5 child, well, he or she requires screening and surveillance, repeated screenings to be done to make sure that the hip has not gone out, or to treat the hip if the hip is subluxated or dislocated. The risk profile of patients for hip displacement, the risk factors are diminishing abduction because of the tight adductors which are present, pelvic obliquity because of the asymmetry between the hips, progressive scoliosis, limb length discrepancy. Well, all these are also responsible factors, risk factors for hip instability. If you have deteriorating gait, the patient could have a hip problem, and GMFC is level 3, 4, or 5. Why to detect early? I think by now it's very, very obvious. If you don't detect early, well, you can't save the hip, and you would have to salvage the situation, generally by means of a femoral head resection and a pelvic support osteotomy, or by some other means, But saving that hip becomes problematic if a large area of the cartilage is eroded. So why is then, hip displacement detected late, Foremost is the fact that professional awareness and education is missing. Our professional colleagues who are dealing with cerebral palsy are not aware about this problem. And cerebral palsy is a multidisciplinary problem. So almost everyone in that chain needs to be made aware that hips can displace, can get painful. Lack of parental and family awareness. They may not come for follow-up for a length of time during which time the hip displaces. Then the problems of access, where do they go for treatment? They're not aware. They come from the rural areas into the cities and eventually find their way to the tertiary care centers. Economic constraints are a huge problem, and mismanagement. So late treatment means poorer outcome for sure, And this is a high index of suspicion. If you have this sort of posture with one of the thighs adducted or both thighs crossing each other, for sure, this child has a hip problem. Well, later on, they may present with groin pain or hip pain, difficulty with sitting, and difficulty with hygiene. As I mentioned, decreased hip range of motion would mean that something is going wrong at the femoral head. Pain with hip motion would mean erosion of the femoral head, gait difficulties, pelvic obliquity, and scoliosis. All these can be associated or features because of a hip dislocation. Now, clinical examination, the combined abduction spread, you can extend the knees and abduct the lower limbs. Well, this is restricted if you have a hip problem. Type 4 hemiplegia, Winton Gage type 4 hemiplegia, which consists of the person having one lower limb in internal rotation and adduction. He's walking, but one of the limbs is in adduction, internal rotation, and the pelvic asymmetry is there. the pelvic tilt is there. These are patients who are prone to have a hip instability. So diagnosis is easy, it's not very difficult. Pain, increasing spasticity, diminishing range of hip abduction, crossing of lower limbs, shortening, and other signs of a dislocation come up very, very late, really. Again, this abduction, I think, is the most important sign, and restricted abduction. Here on the left side, the abduction is restricted, but the posture probably suggests that there's a problem with the right side also. X-rays will show widening of the medial joint space and a broken Shenton's line. What is more important is the Reimer's index, the amount by which the femoral epiphysis is outside the acetabulum when compared to the total width of the femoral epiphysis or the metaphysis, and you express this as a percentage. If 1/3 of the head is outside the acetabulum as compared to the width of the epiphysis or the metaphysis, the displacement will be in the 30 to 35% range. So the way we do these X-rays, that is also very important. The patella have to be facing up and the hips have to be a little flexed because flexion deformity is invariable. So little flexion is required for you to get the correct picture. So migration percentage, 30% is a threshold, important threshold. From there on, the situation at the hip is likely to become abnormal, it's likely to progress. This may be a useful threshold for intervention and a useful goal for outcome. So why now should we be aware about hip displacement in cerebral palsy, and why is there a need for hip surveillance, or repeated screening for hip instability? Well, 35% of the population with cerebral palsy will have a hip displacement. Early displacement is silent, so it doesn't come to the notice, So that's very, very important to know. Natural history is for worsening, as I explained before, and early treatment will preserve hip health and give you a better health-related quality of life. So this is very, very important. By surveillance, we can eliminate hip dislocations altogether, as has been shown in other hip surveillance programs abroad. Now, Indian scenario is alarming. Why is it alarming? Our current population is 1.4 billion. When this was written, it was 1.3 billion in 2021. 3% prevalence of cerebral palsy. The CP pool is 2.5 million. 35% incidence of hip instability means 800,000 patients with 375,000, 375,000 hip dislocations, an incidence of 15%. So early detection and aggressive management of the unstable spastic hip is the key. We have set up a surveillance program by getting together all the stakeholders and thorough review of the literature and existing systems, establishing consensus by the Delphi method, by framing the guidelines, and work on implementation. So stakeholders are patients, professionals, organizations, and government. And professionals, it's easy to get them together. Multidisciplinary people working in the field of cerebral palsy, like the orthopedic surgeon, the neurology surgeon, the neurologists, neurosurgeons, the developmental pediatricians, physiotherapists, occupational therapists, etc., speech therapists, ophthalmologists, and many other specialties. So that's mentioned there here. And getting them all together under the banner of the CP hip surveillance program, just like Alaric explained for the hip DDH program. This was done for the cerebral palsy surveillance program, and many organizations came together under the banner of saving the hip in cerebral palsy. So again, thorough literature review, discussion and consensus via Delphi process, and post-consensus documentation of the literature and creation of educational tools. I'll directly go to phase 3. Phase 1 and 2 were similar to what was mentioned by Alaric. We created the guidelines document and educational tools to make people aware. And this is the Indian hip surveillance scheme, more suited to our population. Important here is that GMFCS patients, they require a lot of screening, and this can be done 6 monthly till the risk goes away. So from the age of 6, 7, you could actually do a yearly screening for them. But before that, one needs to be very active with them to pick up a hip displacement. GMFCS3 annual sort of surveillance program is good enough. GMFCS 1 and 2, very periodic. At the age of 10, we finally conclude. In some cases, we need to follow up, every 2 yearly, even after the age of 10, by means of clinical examination and radiograph. So implementation is by creating awareness, education of all stakeholders, training of ortho and rehab surgeons, and many workshops have been held, standardized recording of data, maintenance of a registry, and by sensitizing the government. Now coming to intervention, management, really I will be very, very brief, just a few slides for want of time. We have 3 levels of intervention. Preventive, which means once you detect a hip instability and it's significant, one would tend to do a soft tissue release. The adductors and the hip flexors overpower. The abductors and extensors, they are tight and they need to be released. Then reconstructive procedures, which combine soft tissue surgeries with osteotomies. So femoral or acetabular procedure, if there's acetabular dysplasia, would need to be done. Finally, for a dislocated hip, where the cartilage is gone, the head shape is poor, one would need to do a salvage procedure. This is palliative surgery for the painful, arthritic, and dislocated hip. So this is given in the algorithm here from mine and Alaric's paper on this subject, and preventive surgery, migration percentage of 33 to 50%, reconstructive surgery for a migration percentage greater than 50%, and salvage surgery for a migration percentage more than 100%. Now, successful outcome is related to age of intervention, a low migration index, and ambulatory status, as you could have made out from my talk, and a proactive approach is necessary. So different details of what procedures can be done are mentioned there, but I think these are very well known to many orthopedic surgeons. So this child whom I showed you earlier, who didn't do anything for about 4 or 5 years, and then had a displacement which increased to nearly 60% here and marked acetabular dysplasia. What would have required a soft tissue release now required a soft tissue release, a femoral shortening, femoral osteotomy, and acetabular surgery. So early detection and aggressive management of the unstable spastic hip is the key. This is very, very important. Now, recently, COVID hit all of us, and then we came up with the COVID vaccine, We said that an ounce of prevention is better than a pound of cure, and this has been stressed from times immemorial. Smallpox vaccination by Edward Jenner, 1796. Shah came up with his injectable polio vaccination in 1953, and 2021 we had the COVID vaccine. Well, these posters were put up during COVID, 2020, 2021. Prevention is better than cure for coronavirus. You need to immunize yourself, this is important. So if we feel that prevention is important, much more important than cure, why not prevention for the cerebral palsy hip? So I would like to conclude by saying that hip migration is a significant issue in cerebral palsy. The non-ambulatory pool has significant hip and spine related problems. Surveillance programs are a must to reduce morbidity. And at each level, every orthopedic surgeon can do his own way, the surveillance in his own way. The guidelines are given. You could follow those guidelines and ultimately benefit the patient by early detection and early management, which will reduce the magnitude of surgery. Well, thank you very much.
Thank you, sir. Thank you for that excellent talk, sir. Are there any questions from the faculty to the sir? Okay, if there are no questions, sir, how early do you think the cartilage gets damaged in hip subluxation?
Well, it varies from case to case. Sometimes I've seen that very, very early, happening very early, and could be a couple of months and things get damaged, It would depend obviously on the degree of spasticity, the GMFCS variety, If the spasticity is severe and they have started subluxating, likely that things will happen very fast, So sometimes they don't follow a particular rule, So I actually had put in slides of a patient where we did one hip, both hips were unstable and subluxated, one was dislocated, one was subluxated. We did the dislocated side, and then this patient actually had some family tragedy. Somebody died in his family, and he came for the second side 6 months later, But 6 months later, when we actually did the surgery, the cartilage was completely gone. In fact, that picture I have put in this particular lecture, but I didn't give you the context. The cartilage had completely gone, and I had to do a pelvic support osteotomy. So this happened within an interval of 6 months.
Sir, if you feel that it is subluxated, soft tissue is alone enough, or you would like to open the hip and see what is the cartilage status?
Well, if it is subluxated, generally things won't be as bad, But if it is dislocated and the head looks fairly round on your X-ray, and you're not sure what you should be doing, should you put it back again, or does it need something of a salvage type of procedure, There I won't hesitate to open and have a look, We try, of course, to do MRI, see the cartilage, all that, But the best bet is actually to open at the time of surgery, have a look, If the cartilage is good, you can put it back. If the cartilage is bad, you need to salvage.
Have you tried any cartilage transplant for these children, like for saving the hip?
Yeah, so what we do is it depends on the area. If the area is large, nothing will work. If the area is small, you could do pitting, drilling, or some sort of cartilage replacement procedure, But generally, this is not done in cerebral palsy. Of course, when we are there and we do sort of pitting, or drilling of that area, But if the area is large, there is no point. There is nothing that you can do about it.
Thank you. Thank you so much, sir. So without further delay, we will go to the next speaker. I call upon the next speaker, Dr. Mihir from USA. He'll be giving talk on slipped capital femoral epiphysis, controversies and consensus. Please, sir.
Thank you very much for inviting me to this. This is great to see everybody here and see that everybody has similar challenges, irrespective of whether you're in the United States or you're in India. So I will talk about SCIFI and what are the consensus and what are the controversies. No disclosures. When we see an 11-year-old like this coming in with pain and inability to walk, the question always is, what do we know? And then in reference to Arindam's talk this morning about, or I guess this evening for you guys, about the haves and the have-nots. What do we know not? So let's go through some of these things. What do we know about SCIFI? We know that there is an epiphyseal tubercle, and SCIFI is an anterolateral displacement of the metaphysis around that epiphyseal tubercle, which over time can lead to a bony prominence with remodeling. And that leads to impingement and eventually osteoarthrosis of the hip, depending on the severity of the slip. We are also very comfortable with the clinical presentation. There's no controversy there. There's limited flexion, there's limited abduction, and there is limited internal rotation with increased external rotation. So that is not controversial at all. You can see the two sides, the normal side on the right and the abnormal or the affected SCIFI side on the left. For imaging, also no controversy. We start with X-rays. What are we looking for? On the AP view, we're looking for the modified Klein's line, so comparing it to the other side, and see if it's more than 2 millimeters different. That gives us a little bit more sensitivity and specificity to the use of the Klein's line. And then we also want to look at what is the skeletal maturity. And many of us use the modified Oxford bone score for this. On the lateral view, we are looking at the severity of the slip. The most common classification that we use is the Southwick. The important thing to understand with this is, you are going to draw the line of the epiphysis perpendicular to that, and then a line down the shaft. So it's the head of the epiphyseal shaft angle, which is the Southwick angle. And based on how you position the hip, this can change. So it is nice to have something to go by as far as numbers go, but don't purely rely on the angles that you measure because they are variable. There are other things that are described, such as the posterior sloping angle, which may potentially help to predict a contralateral slip, and also the posterior epiphyseal tilt. These are still not quite as clear-cut as we would like, because the inter-observer variability, at least for the posterior sloping angle, is about 4 degrees, so that can get you from normal to abnormal relatively quickly. But it's important to pay attention to those. For us to quantify slips, the best thing would be to get good cross-sectional imaging, and that would either be a CT or an MR, which also then gives you whether or not the growth plate is open. But we don't routinely do these for all slips. It's only when you're contemplating a complex corrective osteotomy. Now, let's get started with the controversies, and of these, there are many. So what is not very controversial is the definition of the so-called acute, chronic, and acute on chronic. So less than 3 weeks is what we consider acute. Chronic is really when you see remodeling change, and then acute on chronic is when you see acute change on something that already has remodeling changes. This doesn't necessarily prognosticate or help us too terribly much with how we manage things and how we counsel patients. So Loader, back in 1993, came up with this classic classification of stable versus unstable, where if you're able to bear weight on it, that is considered to be a stable slip, versus if you're not able to bear weight on it, that's considered to be an unstable slip. Now, even within this, there are many controversies. What does weight bearing mean? If you can put a little bit of weight with crutches, is that a stable slip? And also, you look at these slips intraoperatively, and Kai Zebarth from Bern showed that what we thought was stable, intra can be quite unstable. So about a third of what they considered stable based on the Loader classification intraoperatively were found to be quite mobile. And the other way around as well, about half of them that were considered to be unstable intraoperatively didn't really have as much instability. So that really brings into question the use of stable versus unstable. And there you do need to be a little bit careful, but that is still what we end up using quite frequently. As far as treatment goes, the one thing that I think all of us will agree upon without doubt is every slip needs to be stabilized to prevent further progression of the slip and more trouble. The classic Carney and Weinstein article back in 1991 said that regardless of the severity of the slip, in situ pinning provided the best long-term function and delayed arthritis in the hip with the lowest rate of complications. So for a long time, this was the standard of care, irrespective of slips. But when we do that, we have to make sure that the screw is in ideal position. So center of the epiphysis on all views. You have to start a little bit distal to the intertrochanteric line to prevent screw head impingement. Try and be as perpendicular to the growth plate as possible, and have at least 3 to 5 threads in the epiphysis for proper purchase. Now, the challenge with this, though, is even when we look at mild slips, there are many reports coming out now that mild slips can cause significant acetabulochondral injury also. When you look at the long-term outcomes of the so-called standard in situ screw fixation, when you look at, there's a Dutch study that looked at 18-year follow-up with radiographs as well as patient-reported outcome measures, they found that in situ pinning or screw fixation is helpful in mild and moderate slips, but even in the mild slips, they found arthritic change. The Mayo study showed about 12% of in situ pinned hips needed reconstructive surgery. And then Pablo Castaneda showed that every hip, irrespective of its severity, at 20-year follow-up, had evidence of arthritis with in situ pinning. So in situ pinning can give you good short-term outcomes, but long-term outcomes you need to be a little bit careful with. As far as prophylactic screw fixation is concerned, the consensus is everybody with renal disease, endocrine problems, or radiation should get a prophylactic screw on the other side. because we know that for unpinned slips, there is a chance of the contralateral slip, and even without pinning, you can see early arthritis on the other side. As far as the mode of stabilization is concerned, when you look at K-wires versus screws, there's a recent systematic review that showed that screws have much less number of complications. So I think we can all agree on using a screw instead of wires for the prophylactic pinning. What is not so straightforward is the other indications. So looking at the posterior slope angle, which I talked about, looking at the age, looking at the modified Oxford bone score. Is the triradiate a predictor? These are all somewhat more controversial, although the open triradiate, a wide open triradiate, and a low modified Oxford bone score have been shown to have value in predicting contralateral slippages. Now, the challenge is, even when you put a screw in, what happens to the hip after? Is it truly protected? The answer is maybe. When you look at the study by Lurch, about 30%, so 1/3 of the prophylactically pinned hips had a CAM lesion, and about 12% of these actually needed surgery for FAI. So just pinning the hip may not be enough. When you look at what happens when you put a screw in early, then you do end up with trochanteric overgrowth. You can end up with femoral head deformity as well. So where you should be thinking in terms of more growth-friendly alternatives, especially for the prophylactic side. So here's an example. This is an 8-year-old that came in and saw me. This is several years ago at this point. And what we did for him, because we didn't have any fancy implants, is we took a standard screw and filed off the threads on the epiphyseal side, and then put the screw in, followed him along. He grew off of it, so we revised it at about 18 months, and then continued to follow him till physeal closure. And you can see there's good restitution of the head neck offset, so good remodeling seen both on the skiffy side, and the other side remains good also. In today's day and age, you have other options. So this is an example of a 10-year-old, again with an open triradiate wide open growth plates, and you can use the free gliding screw. So that's what we did. We put that in there, and then we continue to follow the patient, and you can see there is distraction across the screw, indicating continued growth of the physes on both sides. So when you look at what the results are for this, Kevin Morash, who was one of our fellows while he was in Canada, looked at the results in their population, and he found that there was much better remodeling, alpha angle improvement in the patients with the free gliding screw versus a standard screw. There are other studies that show that ongoing growth is better, as expected in the prophylactically pinned hips as opposed to skiffy hips, but age 12 seems to be kind of the best predictor. So if you have somebody younger than 12, then you really want to think about a growing construct. So going back to our 11-year-old with the inability to walk, we know that this is an unstable slip. We also know that you don't want to try and get a frog-like lateral view on this and that would cause further compromise to the retinaculum. So get a cross-stable lateral, and then you immobilize them in a position of comfort till they get to the operating room. Controversies is, when do you get them into the operating room? We think that sooner is better, although the data from the UK, where they gave the hip a period of rest, would potentially contradict that. The other controversy is to reduce or not to reduce, and then what really do you want to do from a treatment option perspective. So when you look at reduction, you have your slip, you have the remodeling, and you can see the vessel in the back there. When you try and anatomically reposition, there is new bone formation in the posterior inferior portion of the neck, right where the retinacular vessel goes in. So if you don't address that, then you are going to stretch and compromise the vessel. So that is something that needs to be addressed. And if you're doing this as a closed reduction maneuver, it really is not possible to safely fully reduce the hip if there are evidences of remodeling changes. So when you look at treatment options, you're looking at either in situ pinning with or without an osteotomy later, some form of reduction, whether it's so-called accidental gentle reduction or a Ledbetter maneuver or controlled repositioning through an open anterior approach, or anatomic reduction using the modified Dunn osteotomy. So the one thing that we do know is for the more unstable slips, it's better to have at least a second guide wire in while you're putting your screw in so you don't end up spinning the epiphysis with the torque of your screw as you tighten it. If you can get 2 screws in safely, then that is okay. And as you can see in this particular case, you don't have perfect anatomic reduction. You get to where the hip will allow you to get to. The other controversy is whether or not you decompress the capsule. There are people who have shown that there is decrease in intracapsular pressures when you decompress it with either a cob or you aspirate the hematoma, or you end up with an open decompression. With unstable slips, you can certainly do a partial reduction, see how things go, get it back to where the hip will allow you to, and then you have a cam deformity, which you can deal with as you go. So here we did this with a staged surgical hip dislocation relative to neck lengthening and osteoplasty. Now, the big question is, for capital realignment, should it be done? The Dunn osteotomy has really changed the way we think about SCFE, actually the modified Dunn. Dunn really originally described it in 1964, and Guns repopularized it with the surgical hip dislocation approach in 2001. So what we do with that is we take care of all the callus that is posteromedial, and then shorten the neck a little so we don't stretch the retinacular vessel as we bring that epiphysis back into anatomic position. Eduardo looked at the results, and he found that modified Dunns have similar rates of AVN compared to in situ screw fixation pinning for the unstable slip. And they've had better functional scores, better offset recreation. So when we do these, we certainly can get better reduction, and you can see better function as well in this particular case. The challenge is, why not do it for all of them? The problem is AVN. So up to about a quarter of these patients can get AVN. And when you look at the various different repositioning techniques, the lowest rates of AVN are with the gentle anterior controlled repositioning, the so-called PARSH method. When you look at the modified Dunn, this is a recent systematic review, looked at 636 patients and found about a 10% rate of AVN, which is quite reasonable for something of this sort, especially in the unstable situation. Stable slips typically do not get AVN by themselves, so you really need to think about whether or not it's worth the risk of that 10% AVN in a stable slip as you reconstruct it. How do we decrease this AVN? Blood flow monitoring was thought to be one of the things that would help us with that, and there are various different techniques. Unfortunately, none of them really is good enough to give us 100% certainty, as has been shown by Woodie's group in Philadelphia. We know that SCFE will cause impingement eventually, and there are different levels of impingement with either an inclusion or an impaction cam based on the severity of the slip, but essentially they cause damage to the articular cartilage. So we need to deal with this either with an open approach, especially if you need to bring the trochanter down, or you can deal with it with a scope. SCFE osteotomies, the principle is to improve the impingement-free range of motion, redirect the femur, and correct the head neck offset as well as a trochanteric offset. So I think this is really kind of the key to good hip function, which is correcting the offset. And these can be done at several levels, either at the level of the deformity, which is through the growth plate for a modified Dunn type osteotomy. You can do it at the base of the neck or in the intertrochanteric or subtrochanteric region. You can even do combinations of osteotomy plus offset correction at the head neck junction with either a Watson you're looking at the result. The range of motion and other things are concerned, except for the risk of AVN. And certain
Mihir sir, you are not audible, sir. Mihir sir, and your PPT
Sorry,
is
can you
also not seen in the screen, sir. Can you please reshare your PPT?
My apologies. I think we lost connection. So let me do that again. Is it better now? Can you see it?
Yeah, now it is visible, sir, and you are also audible. You can go ahead, sir.
Thank you. My apologies. So looking at long-term intertrochanteric osteotomy, long-term follow-up at 24 years, almost half of them had arthritis. We don't really have that much of a follow-up for the modified done yet. Looking at the best possible results that we can, which are from the Swiss group, they found at 10-year follow-up, no AVN, and about 1 out of 5, 20% of them had secondary impingement surgery. So it is not necessarily the end-all be-all. We still probably need to do other things along the way, but it certainly seems to be a good option. So to sum up, as far as the consensus is concerned, we know that all slips need to be stabilized. For the mild slips, in situ pinning is still a very reasonable option. For the moderate to severe slips, we really need to think of other things. And we do end up with an increased risk of osteoarthritis in the long term or the medium term, even with the moderate to severe slips. Unstable slips are at high risk of AVN, so more aggressive interventions may be entertained. And blood flow monitoring for these is unreliable intraoperatively. Where it becomes a little less clear is for the moderate to severe stable slip, do we want to run the risk of the 10 to 20% risk of AVN when we do a modified done for these? For the unstable slip, how quickly do we need to get them there? What's the best way to reduce it? And is there anything that we can do to reliably predict and reduce AVN? And which osteotomy is better than the other? So this is my kind of thought process algorithm, so to speak. If I have somebody with an open growth plate, then for a mild stable slip, they will get an in situ pinning, plus minus an osteoplasty later if needed. For a moderate to severe deformity, they typically will get a pin followed by a modified done or proximal femoral osteotomy. I tend to favor a proximal femoral osteotomy for the stable slips, plus offset correction with a surgical dislocation approach. For the unstable slip, it is much more likely that if it's a moderate to severe unstable slip, then we will go the modified done route. But you can do an anterior controlled reduction as well, which actually has, per literature, slightly better results. For closed growth plates, life is a little bit more challenging because for the mild slip, it's pretty straightforward. You can do an osteoplasty these days, mostly with a scope. But for the more severe deformity, a neck osteotomy is associated with higher risk. So you might want to think of a proximal femoral osteotomy plus an osteoplasty. So those are my thoughts. Thank you very much for allowing me to share them. Welcome any questions.
Thank you, sir. Thank you for the talk, sir. I'd like to thank Dr. Mihir, who has joined all the way from the United States of America on early morning of a Sunday to give this wonderful talk. Thank you so much. It was very elaborative, and Skiffy is one which needs a lot of attention, and a proper treatment at the proper time can get good results. And I think with this talk, we have come to the end of the session.
One quick question to Dr. Thacker. Would you do a prophylactic nailing in the other hip? Because some of these cases are bilateral. So would you do something for the other side?
Yeah, thanks very much, Arindam. That's a good question. And I think for the more straightforward indications, that would be if it's a atypical slip, right? So somebody with either renal disease, endocrinopathy, or for some less common indications, like, I had a kid with Ewing sarcoma of the pelvis that we ended up radiating, who ended up with a slip on the one side. So those I will prophylactically pin on the other side. For me, I think an open dry radiate is a higher risk. So you look at the modified Oxford bone score for sure, but open dry radiates typically translate to a lower modified Oxford bone score. So the risk of contralateral slippage is quite high. And in those situations, I would certainly talk to the family about potentially pinning the other side. And like I kind of very briefly talked about, it's important for us to think about what we are putting in on the other side as well. And you need something that is potentially going to be more of a growth-friendly option.
Thanks.
Well, thanks very much for having me.
Hello, sir. Sorry, there was some connection issue. Hope everybody can hear me.
Yeah.
Yeah. So with this talk, I think we are coming to the end of the session of faculty talk. I think we can go ahead with any questions from the participants, if there are any, or from the faculty, we can go ahead with the discussions.
I think you have some good cases lined up, Arvind. So why don't we put up those cases, because we're already short of time. We just have half an hour more to go. So
Okay,
why
so
don't we
I think we
discuss the
will go
cases?
ahead with the case discussions. So first, I would like to call from KMC Manipal, Dr. Surender to present his case.
Is it visible, sir?
Yeah, it is. Siddharth, it is visible. I think you can start presenting. Thank you.
Yeah. Thank you for the opportunity. I'm Dr. Siddhartha from Kasturba Medical College, Manipal. I'm presenting a case of a 10-year-old male child who presented with history of slip and fall while trekking and presented 10 hours after the injury, and he has complained of pain and inability to move and weight bear on the left lower limb. On examination, there are no other significant injuries, and distal neurovascular status is intact. A plain radiograph of pelvis with both hips shows there is a fracture of capital femoral epiphysis, transfacial fracture with dislocation, and the place of dislocation of the physis is not very clear. The CT shows there is a clear posterior dislocation of the capital femoral epiphysis with proximal subluxation of the femur. At this point, we have questions on how do we manage and proceed further. So whether we treat it with closed reduction or open reduction. Most of the fractures neck of femur can be reduced by closed maneuvers and can be fixed internally. But few cases in which the reduction is non-congruent, or there is soft tissue interposing between the fractures, or there is a buttonholing of the femoral head through the capsule, then open reduction is necessary to get the reduction and maintain the congruity. So when we plan for open reduction, how do we approach the case? Whether we approach it through anterior approach or posterior approach. Though the anterior approach is more familiar with the pediatric or the surgeons, in case in which there is posterior dislocation of head, it is difficult to reach that fracture fragment and reduce. So we need to approach through posterior approach, though there is high chance of avascular necrosis reported through posterior approach. And also, how do we fix the fracture after reduction, with K-wires or screws. Though K-wires, the stability is questionable, but there is a chance of growth potential remaining at the physis. But with screws, fixation is stable, and there is a chance of early fusion of the physis. With these in mind, we'll see how this case was managed. Initially, a trial of closed reduction was done, which failed inevitably, and then open reduction was performed with the posterior approach. Intraoperatively, femoral epiphysis was seen to be present posterior to the capsule and just beneath the gluteus maximus. And there is avulsion of ligamentum teres and osteochondral fracture of the posterior lip of the acetabulum and labral avulsion. It is managed with the ligamentum teres excision and fracture fixation, anatomical reduction of the fracture and fixation with cannulated cancellous screws, and the repair of osteochondral fracture of the acetabular rim and repair of the labrum. And postoperatively, skin traction was applied. So this is X-ray immediate postoperative showing anatomical reduction and stable fixation with the cannulated screws. So after 3 weeks after the surgery, because there is high chance of avascular necrosis with Delbert type 1B transphyseal fractures, we have done a bone scan 3 weeks after the surgery, which shows that there is no evidence of avascular necrosis of the femur, and there is mild reactive radiotracer uptake in periprosthetic region. And in follow-up at 4 months also, a repeat bone scan was performed to see for evidence of avascular necrosis, which shows there is no avascular necrosis, but there is signs of early fusion of the physis on the involved side. So on follow-up, the range of motion is good, and there is early fusion of the physis, and there is development of coxa breva. And at final follow-up, 2 years, 6 months follow-up, there is a range of motion is good, but radiologically there is coxa breva and coxa vara compared to the normal side, and there is negligible limb length discrepancy. So this is the functional range of motion at final follow-up. So the fracture neck of femur, prognosis is affected by following factors as depicted in literature, that is age, type of fracture, displacement, vascular insult, reduction and stability of the fixation. Transphyseal fractures have a highest risk of impairment of blood flow and avascular necrosis leading to early arthritis and stiffness. Early open reduction and internal fixation is preferred in such injuries than closed methods. Finally, I'd like to say that early intervention with careful preservation of anterior retinacular soft tissue may get a good results without avascular necrosis. Thank you.
Thank you for that case presentation, Siddharth. The case is open for discussion. So faculties, everybody can just pitch in and then give their opinion regarding the case.
Thanks, Aravinth. I think in the interest of time, we'll just take 1 or 2 questions because this is really a fantastic result. I think you're extremely lucky to get an excellent result like this and with good follow-up for a type 1 fracture where the risk of AVN is almost 100%. So maybe a couple of things that you can explain with the posterior approach. Now that we know the studies done by Gans of the blood supply of the femoral head, what tips and tricks do you suggest? How do we take, because we know we can't take the standard posterior approach, taking off the external rotators as we do in adults when we're doing a total hip, for example, because we know that the blood supply comes in from there. So what precautions did you take in the posterior approach to preserve the blood supply of the femoral head? And secondly, the other question would be, if you have a younger child like this, where you know that there's a chance of physeal closure, maybe once the epiphysis was reduced well, you could do an early implant exit. So, maybe at 6 months or so, whatever little growth was possible there would have happened with the growth of the femur. So,
sir, in this case, there is a posterior dislocation of the head, and there is a rent in the posterior capsule, which suggests that there is maybe disruption of the posterior retinacular vessels. So approaching through anteriorly, it might also damage the anterior retinacular vessels, which might further impede the vascularity. So approaching posteriorly, I think would be the logical thing. And also while
Yeah, I don't deny
doing
that. I'm just
surgery,
saying that when you did the posterior approach, what precautions did you take? All of us would have approached
yeah,
it posteriorly.
we try to limit the damage to the medial circumflex artery at the quadratus muscle and stay superior to it or proximal to it, and a careful dissection and reduction. And regarding the growth left, I think when there is severe transfacial damage, fracture, there may be damage of physis, and literature shows that there is early fusion of the physis despite of whether we put it with K-wires or screws. So due to the amount of high velocity injuries or high energy trauma, there may be inevitable fusion of the physis. And stability
can
is
tell
more important than the K-wire fixation or the growth, I prefer. And the growth potential of the growth contributed by proximal physis is also less, approximately 4 mm per year. So that would not cause much limb discrepancy and disturbance.
So two quick things, if I may. One is, along the same lines as Alaric's question, you know that the proximal femoral growth plate is going to fuse. You know that the trochanter is going to stay open. So any thoughts towards closing the trochanter prophylactically when you do your initial reduction? If you do it using a surgical hip dislocation approach, then you're going to close the trochanter in any case, so that's not a problem. But if you're doing it on a posterior approach, then one of the things to potentially consider is closing down that trochanter to minimize the trochanteric overgrowth. He's 10, so it's probably not so much of overgrowth that you would expect. The other question was, it looked like when you had your final x-rays in there, when you took your hardware out, did you also do an offset correction? Because it looks like there was some osteoplasty that was done at the same time, which then would explain why you have such good internal rotation, because your initial x-rays with the cam deformity and the coxa brevis don't necessarily lend themselves to that good of a range of motion.
During implant removal, we didn't do any kind of this procedure for the osteochondral fragment or something like that. And during follow-up also, we didn't encounter any overgrowth of the physis. So we didn't, and there is, limp is also not too much appreciable. So we didn't go on to do physiodisis.
It's great result.
On the X-rays, Siddharth, there is a reduced articular trochanteric distance. So if you see your X-rays, they show
Yes,
reduced.
sir, definitely there is
ATD.
a reduction.
Did you not think of a standard surgical dislocation approach? Considering that very highly unstable fracture, chances of growth arrest very, very high. Why did you not do it from the lateral approach?
No, sir. Actually, I can tell that all the question that then when we saw the child, generally with the dislocation, same surgical dislocation, we take it anteriorly, where the capital epiphysis was kept posteriorly to the acetabulum. So that is number one. That's why same surgical dislocation we did not. We did not go beyond the quadratus. So that's proximal only dissection was done. And primarily, we only thought about reducing the epiphysis. So that is reason trochanter was not done anything. While implant removal, we did actually trochanteric epiphysiodesis. So whatever coxa breva is there, it will remain the same. So we did that. And the third question where the Alaric asked that actually why not to do the primarily, as Mihir also said, the primarily as that it is the avian is almost 100%. It is reported up to. So the primary focus was to salvage the hip. If hip it is salvageable, then we can do anything like offset correction or osteocostochondry or greater trochanter or coxa breva correction. That was a goal actually. Primary.
It looks great, Hitesh.
Thanks.
Let's go ahead with the next
It is just
case.
one passing comment, that through a safe surgical dislocation, you take off the piriformis, you reach exactly where
Same.
you reach by a posterior approach, So no difference there really. I mean, it's posterior and the head is lying there. You preserve the retinacular vessel and reduce that, So anyway, I think your choice of approach is fine. It worked out very well, but that would be an alternative way of looking at it.
Yes, sir. Definitely. Yeah, Alaric, you are telling something? Sorry.
No, I was saying let's move to the next case. I think because we've got, I think, 3 or 4 good cases. We're already running out of time.
Yeah, fine.
Thank you, sir. Thank you for the excellent discussion. We will now go to the second case discussion by Dr. Karthik from PGI. Karthik?
Yeah, good evening, everyone. Is my screen visible?
Yeah. Can you just share your PowerPoint?
Yeah, I have already shared. Is it visible now?
No, it's not yet visible.
Share it on Zoom.
Yes.
Karthik, your screen is visible.
Yeah, just a minute. Is it visible now?
Yeah, it's visible. Make it full screen, please. Yeah, you can go ahead.
Yeah, good evening, everyone. First of all, I want to thank the WOC team and Dr. Vishnu for giving this opportunity to present in this platform. So I am presenting an interesting case of pediatric hip dislocation that was overlooked initially. So this is a 13-year-old female child. She met with a road traffic accident while she was a pillion rider. She met with accident with a truck. She went to the regional government hospital where they took an X-ray and they diagnosed hip dislocation and they did reduction. But the exact records were not available. So 3 days later, they presented to our institute, presenting with pain in movement of right hip and inability to sit. On clinical examination, she had anterior joint tenderness present and the hip is extended and externally rotated. Any attempt to move the hip was very painful. So these are all the X-rays that was taken in our institute. You can see the anteroposterior and the pelvic outlet. In the anteroposterior, you can see there is a non-congruent hip joint reduction with the increased medial joint space. In the pelvic view, we got the Judet view also. Here in the pelvic view, during the Judet view, you can see a small fleck of bone that is placed inferiorly that causes some suspicion that there is some loose body inside the hip joint that makes the joint non-congruent. So we proceed with further investigation. We got a CT scan done. Here you can see in the axial cuts, there is a defect in the fovea and there is a loose body that is the fleck of bone that is present inside the joint on the posterior aspect. So these are all the sagittal cuts and the coronal cuts. Here also you can see foveal, there is a defect in the foveal cut and the loose bone is lying inferiorly. So since there is an intra-articular loose body with a non-congruent hip joint and we proceed for surgical intervention, we proceed with a safe surgical dislocation as described by Professor Gans. So these are all the intraoperative pictures. You can see the foveal defect and we are holding the ligamentum teres with the fleck of osteochondral bone that was avulsed from the femoral head. Since the bony piece was very small and it is non-fixable, we excised the osteochondral bony fragment along with the ligamentum teres. And intraoperatively after the reduction, we can see we found there is a postero-superior labral injury and we repaired those injury also using 2 suture anchors. And we fixed the trochanteric flip osteotomy using the 2 screws. So we did a 1-year follow-up. The child was asymptomatic. We didn't perform any MRI scan, but the radiograph shows no any signs of avian or any early signs of arthritis. And she is able to perform routine day-to-day activities and she is totally asymptomatic. We will follow her for a long time. So only 2 cases are reported in the literature. One is from Sydney that was published in 1990. This is a 5-year-old child having a avulsed ligamentum teres and they did a modified Smith-Peterson approach and they excised the fragment. Another is from Japan that was published in 2000. They did an arthroscopic excision of the ligamentum teres. So I conclude So after a hip joint dislocation reduction, look for congruence of the joint. If there is an incongruent, the possible reason may be soft tissue interposition like capsular interposition or labral injury, or it can be a bony fragment. It is an incorporate fragment, either avulsed ligamentum teres or an acetabular epiphysis. It can be addressed surgically by either safe surgical dislocation, or if you are having any expertise in hip arthroscopy, that is the best thing. Thank you.
Thank you, Karthik.
Any questions?
This was open for discussion. Any questions from the faculty, please?
Karthik, that's a good case actually. And I have seen this patient actually, the paper which was reported from Japan, So I've seen that particular patient. So arthroscopically that was taken out. I think arthroscopy is a much easier approach when you have this, especially inferiorly, on the inferior part of the acetabulum. It's very easy to go, arthroscopically and take it out. And the experts actually will do it very easily. We need not do a big elaborate surgical procedure for that.
I am having one question to the panelists, sir. If we see a incongruent hip joint after a posterior hip dislocation in a child, what is the investigation of child? Because in the adults we do CT scan, but in the child it can be a soft tissue interposition also, whether it is an MRI or it is a CT scan. What are the expert opinions?
Obviously, in a child, we would do a MRI.
Yeah, I think all of us would agree that the MRI is a better choice because you can see, as you saw in your case as well, you can see capsulocerebral injuries, which then can get interposed into the joint, giving you the asymmetric reduction. And you will not necessarily pick those up on the CT. So it's better to get an MRI. Okay.
If there are no further questions, I think, thank you, Karthik, for that excellent case. We will go for the last case presentation for today's webinar. Call upon Dr. Sukalyan from Guwahati to present his case. Please, sir. Yeah, your screen is visible.
Yes. For the want of time, I'll move a bit quickly. It's my privilege to take part in this World Orthopedic Concern. And let's directly go to this case. A 14-year-old male who is physically active, and he plays cricket often in the school team, and he has been complaining of progressive pain in the right hip since last 3 months. He can walk, but he can walk with the limp, and that has been growing worse and worse as the day goes by. There is some rest pain as well. He feels a bit of pain at night as well, but there is no incidence of or weight loss or any fever. And that's how his physical examination looks like. On examination, he has a fixed flexion deformity of 30 degrees, and the rotations are severely restricted. And abduction is only 20 to 40 degrees. And we got an X-ray done, and it shows a lighting lesion with surrounding sclerotic bone. There was also an MRI done, but the films got damaged and I could not produce it today. But it showed a lytic lesion, had some cortical disruption and some reactive joint. And it was described to be of chondrogenic origin, probably chondroblastoma. We went ahead and did a genital biopsy, and the biopsy suggested of chondroblastoma indeed. So we were confronted with 3 options. One is to perform a surgical dislocation, as my previous speakers have done because of various reasons, and do a curettage and grafting. But already there was a cortical breach which was present, and the cartilage looked non-salvageable. The second option was to do head resection and fit it with a prosthesis, but his physis are still open and some growth was left. And the third option was to perform a head resection and pelvic support osteotomy. The mention of pelvic support osteotomy for various reasons was made earlier on the day, and that's what we did in this case. Moreover, the child and the parents wanted a one-time solution, and the child wanted to do heavy activities. So we did a pelvic support osteotomy, and the principles are already elucidated in literature. That is, when the head is not there anymore, the proximal femur comes under the pelvic bone and supports it, provided the length and the mechanical access are optimal. So to calculate how much and where to do the pelvic support osteotomy, we take a maximum adduction. And so because that's where the head is going to, the proximal femur is going to come under the pelvis. And then also add another 15 degrees because the soft tissues tend to stretch with time. And that's why the distal fragment of the first osteotomy goes on becoming abducted. And that's why we had a second osteotomy at a distal point, aligning with the mechanical axis of the whole lower limb and give it a bit of wear. And then we go on lengthening the limb. Now, essentially, that's why it is a double osteotomy. And there are various modes of fixation. So what we did is we fitted it with LRS, and proximal osteotomy can also be fixed with plates or Ilizarov fixator. We chose LRS because Ilizarov is sometimes bulky and it might not be comfortable to the child, and LRS can provide a simple construct. In providing that, the mechanical axis should pass through the center of the knee at the end of the lengthening process. So the trick is to pass the proximal pins distalwards in with respect to the shaft of the proximal femur, and the middle fragment, they should be from distal to proximal, and on the distalmost fragment they should again be proximal to distal. They would be looking a bit distal, so that when it is aligned, they more or less come parallel to each other. The useful thing is to have a swivel clamp around, because if any adjustments are to be made, that can accommodate a small amount of adjustment. So that's how the construct was created, and the child was taken to full weight bearing after the end of the procedure. And also, through the posterior approach, we excised the head and sent it for biopsy, which again came out to be controlled. So as you see, the lengthening and consolidation process is going on, and the child is continuing to bear weight. And once we got the appropriate length, the fixator was removed. And sometimes we have to distract it more than the usual 1 millimeter per day in 4 installments, because children's bones grow much faster in some of the cases. So that's how he is working at the end of 18 months. And you can see that the length has been more or less restored, and the mechanical axis has also been restored. And that's how he is running. So he's back to playing sports. He could not play as good as his previous times, but he is in the field. So the take-home points are some of the lesions of proximal femur may render it non-salvageable, and then we have to think about giving it a stable and mobile hip or a pseudo hip with some kind of procedure like this when he has not graduated to the age of having a replacement done. If well performed, it can give a stable pseudo joint with good function and stability. LRS is one of the options for fixation. That's all it is for today.
That was a very good case, Sukalyan, and I think now it is open for the faculty to pitch in their comments.
Sukalyan, very nicely done. Your mechanical axis looks very nice. You're a little bit short, but that's okay. That is stuff that can be adjusted. I just want to go back to the chondroblastoma initial management. So, clearly it's an epiphyseal lesion, looks like a chondroblastoma. Your biopsy proves it's a chondroblastoma. As far as treatment choices go at that point, it may have gone into or come through the articular cartilage, depending on where the location of that articular cartilage breach is and how big that articular cartilage breach is. You can still potentially approach it from a surgical hip dislocation approach, take the head out, scoop out all of the chondroblastoma, and then you have two choices if you want to try and retain the head. One is if you have an osteochondral allograft that's available, then you can match it and do like an oats kind of procedure. So that is one choice. The other choice, and this is something that I've done also, is if the articular breach is not too big and it's away from the weight-bearing portion, then what I've done in the past is I've cured out the chondroblastoma and then put in calcium phosphate cement, not your standard PMMA, but a bioabsorbable kind of cement, which gives you some degree of structural stability. And then you can use your ligamentum teres to kind of cover over the area. So you can suture the ligamentum to the edges of the chondral defect, and that tends to work quite well also. But that is depending on the size of the cartilage breach and also the location of the cartilage breach. But those are things that you could potentially think about also if you wanted to try and salvage that head, if the chondroblastoma allows you to do that.
Yes, excellent suggestions. So here in my city, I don't have access to osteochondral allografts, but as you said, those things could have been done. Yes, that's right. The chondral defect, for your information, was covering about 40% of the weight-bearing portion. Yes,
So
it could have
it
been.
becomes hard. Yeah.
Thank you, sir. I think that was a very good discussion that went in with this case. I now request Dr. Chinmay Nath, sir, to pitch in his vote of thanks for this session as we draw to the end of the session. Over to Chinmay, sir.
Yes. Good evening. This is the end of this nicely designed webinar on pediatric hip problems. Though I'm not a pediatric guy, I'm a spine doctor, spine surgeon. But as a secretary of WOC India, I want to mention some points that with the SICOT leadership since the days of the COVID, we are using the webinars as a good learning tools, and we are maintaining these in WOC India also. So last year we have organized 5 very successful webinars by Dr. Vishnu Senthil, and also one by myself and two by Dr. Saseendar. And all the 5 webinars were very successful, and people watched over the OrthoTV as well as the different social media and directly. So now I think this is our first webinar this year 2025. And I think we have to, because now we need also the physical meetings. So under WOC India banner, we have to start physical meetings and also the hands-on workshops in different and kind of workshops in different specialties. So we will start. I'll come to it later on. So this in this webinar, I think. So can you see my slides?
Yes. It is visible. You can make it as a full screen.
Yeah. So
yes,
this
sir.
webinar was suggested by our president of WOC International as well as WOC India, Dr. Arindam Banerjee. I thank him. I think he has left for his some other jobs. So with continuation by Dr. Arindam Banerjee, I also thank all the 4 stalwart speakers, among them Dr. Professor Ashok Johari. He is the stalwart of the stalwarts in pediatric orthopedics, and he's the guru and our lighthouse in SICOT as well as in WOC. I thank Dr. Alaric. He's a very well-known pediatric orthopedic surgeons all over the world. So he has given us a good topic and elaboration, as well as Dr. Hitesh Shah from India, and Dr. Mihir Thacker all the way from USA at morning. He has joined. So, and all the case presenters, the moderators, Dr. Vishnu, Dr. Aravinth. I thanks Dr. Siddharth Kamath of Manipal, Dr. Syed Faisal from Lucknow, Dr. Karthik from Chandigarh, Dr. Sukalyan Dey from Guwahati, and also all the viewers who have joined in OrthoTV, Facebook, and all other social medias. So this is a very successful webinar, I believe, and many people have joined, and discussion is also very fruitful. So we will be continuing to organize such webinars in different subspecialties and topics in the banner of WOC India. And also let us start the physical meeting. And in Kolkata, we are organizing one webinar on spinal injury management and rehabilitation. Along with it, there will be a sawbone workshop on spinal trauma and fixation techniques. There will be 12 faculties from orthopedics, spine surgery, as well as from physical medicine subspecialties. And it will be at JIS School of Medical Science and Research. It's a new private medical college in Kolkata came up, and I am a professor in that medical college. So we will organize in that medical college one-day webinar. And after that, in 17th, 18th May, there will be first annual conference of WOC India at Kolkata, maybe at Park Hotel. We will finalize with Dr. Arindam Banerjee the venue. Maybe most likely it will be at Park Hotel, which is at the central part of the Calcutta and not very far from the airport. So I'll invite all the WOC members and all the faculties to join us at the first WOC annual conference, WOC India annual conference. I'll also thank the Vice President of WOC International as well as Vice President of WOC India, Dr. Saseendar. He just left for his flight for Singapore. And with his and with Dr. Banerjee's encouragement, I think we will come up with newer sort of educational modalities, and also we are planning some fellowships for the backward countries, and also some district, the practicing orthopedic surgeons at districts. So let us bring our WOC India and pull WOC India to an international level and continue our educational activities. And I'll request Professor Ashok Johari to bless us and guide us in this and all other faculties. So thank you very much for joining and organizing this fruitful webinar. Thank you all. Good night.
Thank you.
Thank you. Thank you, everyone.
Thank you.
Thank you very much.
Thank you, sir. Thank you, everyone.
Thank you, sirs. I think we will conclude the session. Thank you so much.
Thank you, everyone.
Thanks. It's great seeing everybody.
Thanks. Bye.
Bye.
Sure.